Hi, welcome to today's community chat. We're going to be speaking about RSV. It's something that the FDA just approved a new drug for, but there's much more to speak about. So we are bringing an expert in. We have Dr. Randall Fisher here with us from CHKD. He's an infectious disease specialist, and he has been working with RSV and other diseases since the beginning of his career. So I'm just going to turn it over to him to just talk a little bit about what his background is.
Hi, Sarah. Thanks for having me on.
Absolutely.
When I first started studying infectious diseases at Vanderbilt, I was trying to figure out what I wanted to study, and I was very interested in RSV because it's a virus that affects babies, and I'm a pediatrician. So there happened to be a lab there that was studying RSV at the time. And so I studied with Dr. Barney Graham there for 2 years there. And then I went to Duke University and continued laboratory study of the virus there, looking for ways to prevent RSV disease. We particularly did study passive antibodies, which is what we're going to be talking about later. So I have some experience with the antibody idea of prevention of RSV.
And, thank you for bringing that up. So the new treatment, for those that don't know, it's going to be an antibody drug that is going to be for children that are infants, babies, and then potentially 2 years of age, if they're going through their second season and they're more vulnerable. But for you, I mean, you've seen this development grow, I'm sure, over your career, and now we're just sort of starting to see some treatments available. There was a first one that was for premature babies. There's a vaccine that now exists for, more elderly patients. But here we're in a new group, a new age group that is going to potentially have this new drug, barring, approvals from the CDC and advisements. But I mean, how can you just talk a little bit about that? Because that sure has made such a growth or a curve, over your research, I'm sure.
Yes, absolutely. Originally, there was concern that antibodies might not be very good for babies with RSV because the original vaccine made antibodies, but then kids got really sick anyway. But it was discovered that the more antibodies you have as a baby, the better protected you are. And so originally they started using pooled antibody, and they'd have to give a big infusion of pooled antibodies to prevent RSV in high-risk babies. And then they developed a monoclonal antibody, which is a much more specific antibody. And that's what we've currently been using. And the issue with the current product is that it has to be administered once a month because it doesn't have a very long half-life. So you have to bring the babies in, give them an IV, or sorry, this is an IM medicine once every month through the duration of the RSV season, which is typically about 5 months. The new product is also an antibody, just like the old one, but it has a much, much longer half-life. And so the beauty of it is that you could give a shot of this at the beginning of the RSV season, and it will protect the baby the entire 5 months with no need for further visits, no need for any further injections. But it works the exact same way as the old one does. And we've been using that old one for years, so we know it works very well.
And, just talking about normal routine here, going every month to take your child in, that can be difficult for a family, and that can be a difficult thing to do, especially maybe you're in an area that doesn't have the same medical care, or you're working. I mean, there's so many reasons why that would prove difficult for families.
Yeah, absolutely. And of course, we've targeted this intervention to babies that are at the highest risk for bad RSV disease. And that would generally be babies that are born prematurely, or babies who have immune deficiencies or who have lung problems or heart problems that put them at higher risk of getting very, very sick with RSV. For now, this new medicine will also be targeted probably at the same groups, but they may expand that over time.
And that answers the question of, what groups have a higher risk. It is some babies that do have, some lung issues, or some that may be born prematurely. I mean, for the average child that is healthy, they can still get severe cases too, though, right?
Yeah, absolutely. So let me just give you a little more background about the virus
Absolutely.
itself. The virus circulates widely, and prior to COVID, it had almost a very predictable seasonal pattern. It would come around in this part of the country, usually in November, and then it would go for 5 months. And then it would pretty much disappear and then come back again. And every other year was slightly worse than the year before. That was the established pattern. When COVID came around, it threw that for a loop. And before that, we never ever saw cases in the summer. But this last summer, there was a little higher amount, a big outbreak in July that sort of went through August and then tapered off. And then it came back again in October through January, which is more like the typical time frame. It's so common that about 60 to 70% of all babies get infected during the first year of life. And by the time they've lived through 2 seasons, 100% essentially have been infected. Now, for most babies, it just causes a respiratory syndrome, that's more like a common cold. And even in the babies who end up sicker, it kind of starts like that for a few days, a little sniffles, a little common cold, maybe a little fussiness. But then in the ones who get sicker, it then goes from the upper airway down into the lower airway. And when that happens, then they can start having difficulty breathing. Wheezing, you can see their chest moving hard, they breathe too fast. If you check their oxygen saturations at the hospital, you see some of them need oxygen. And those are the babies that end up in the hospital.
And, for those severe cases, besides, maybe difficulty breathing, are there signs that point, that it might be time to seek, maybe more extreme care, taking them to the hospital, taking them to the ER?
Sure. I mean, if you have a term healthy baby who has cold-like symptoms and they're not having difficulty breathing, they're continuing to eat well, they're continuing to wet their diapers at the normal rate, that's probably not a need to go see a doctor. They probably don't have a need to go see a doctor. But if they begin to have difficulty breathing, I mean, maybe the first thing would be the breathing is too fast. And then you can see, if you watch them breathe, you can see they're tugging at the up here, or you can see the chest like working where the ribs are showing. You can tell that it's more difficult for them to breathe. That's when you start to get worried. And those children definitely need to be seen by a physician.
And the CDC says that it's 1 to 3% of children under 12 months that will end up being hospitalized for it. But in terms of children that have cases, I think it said about 58,000 to 80,000, younger than 5 that are hospitalized due to RSV infections each year. And then, in general, you said, maybe about 60 to 70% of children do get some version of RSV, whether mild or more severe. I mean, that does seem to affect a lot of that range.
Yeah, absolutely. So you're correct that the hospitalization rate of the entire birth cohort is about 1 to 4 or 5% at the most. For these kids who are at higher risk, though, there are some studies where it's 10%.
Wow.
So it's somewhere between 5 and 10% of all these babies that have these risk factors we talked about before that end up getting sick enough to require hospitalization.
And for those who hear antibody, I think the first thing you think of right now are, certain COVID vaccines, or certain things like that. But this is something that you obviously take prior, but it doesn't operate like a vaccine. It's helping you through a season, or helping you sort of get through without those prior antibodies, or what is it doing?
Yeah, so I mean, one way to think of it is it's like a passive immunization. A vaccine is an active immunization, meaning that we give you something that's designed to make your immune system make an antibody, right? In this case, we're just giving the antibody. So instead of asking the baby to produce an antibody, we have an antibody that's been produced that we just infuse into the baby, or in this case, put into the muscle, and that so they don't have to make an antibody response. We essentially just provide one for them. So one way to think of it is a vaccine is active immunization, meaning the patient has to participate in it. But this product is passive immunization. All they have to do is go there and get the injection, and they're provided with the protection.
And if you're a baby, you're born either before or during a season, you might not have any of those real world immunities yet. So, that is interesting that it sort of just gives you this layer of protection.
Right, correct. I mean, babies do get antibodies from their mothers when they're in the womb. And for that reason, a lot of babies in the first 2, 3, 4 weeks of life don't tend to get sick enough to be hospitalized because they have some protection from a passive antibody they got from their mothers, in the same way that we're providing protection with a passive antibody. Those antibodies go away, and then those babies from about ages, say, 2 months to about 10 or 11 months are sort of at the highest risk of ending up getting really sick because they don't have antibodies left over from mom and they haven't had time to make their own. So that's where this product steps in, is it provides that antibody to bridge that gap. And like you said before, a lot of these kids, once they get through the first season, then they're probably okay for the second season, although there are some children who have higher risk with worse disease that might qualify for getting protected through the second season as well.
And, for cases like this, and you talked a little bit about what happened post COVID, we've heard words like triple pandemic or triple demic or, different ways to sort of say flu, COVID, and RSV. Obviously, that's interesting when RSV popped up in the summer, you're sort of taking it out of maybe the normal equation. But for last year, we had a case that a story out of Richmond. They were saying, it was so backed up in some of the hospitals they visited with a child that had severe RSV. And, that causes concern if you don't have certain machines or space available at hospitals to treat some of these children.
Yeah, I mean, the triple demic was kind of interesting. Obviously, like I mentioned before, in the past, we had a very distinct season. And when COVID came, it sort of interrupted the ecology of the virus and it made it so that it was much less predictable. But it seems like, and I'm hopeful that as we move forward in time, that we'll go back to that sort of more predictable pattern. Certainly, that would make it easier for us to protect babies because even with this new product, we give the injection, it protects for 5 months. If we knew when the virus was coming, then we could give the injection right before it gets here and make sure that they're protected through the duration of the epidemic, of the outbreak.
Right. And in terms of, the other sicknesses too, it is possible that a child presents with COVID or the flu or, I mean, what are some things that, I guess now we have a COVID test, we have flu tests to sort of rule those out. But, is that a worry that can you get multiple sicknesses at one time? Can that be difficult for the health system if you have children of different sicknesses in your home or in your facilities?
Yeah, let me take those sort of one at a time.
Yeah.
As to whether you can get more than one illness at the same time, the answer is unfortunately yes, but it's not as common as you might think. So we know that there are other viruses that also circulate. There's other respiratory viruses that circulate. And people have done studies on children who are hospitalized with, for example, RSV, looking to see if they have any other viruses as well. And some of them do, but it's a small subset. So typically, if you have RSV, you have RSV, and if you have flu, you have flu. And although there's a lot of overlap in the symptoms, some things about it are a little bit different. So for RSV, it's much more likely to be severe in a baby than it is in an older child, whereas flu is severe at all ages. The incubation period for flu is very short. If you get exposed to flu, usually within 48 hours, you become sick with flu, and the onset is explosive. You might feel fine, and then 2 or 3 hours later, you're on the couch and you feel horrible. With RSV, the onset is much more, the incubation period is longer. So if you get exposed, it might be 4 or 5 days before you get sick. And then the onset is much slower. You develop respiratory symptoms that are mild and are located in the upper respiratory tract first. And then if your immune system is exposed, has been exposed before, it ends there. But if you're a baby and you've never had it before, it's possible that it could then go down into the lower respiratory tract and begin to cause the problems with the breathing that we talked about before.
So as a parent, if you're dealing with a sick child, your pediatrician, or if you have to go to urgent care, there are certain signs or ways to sort of maybe give them information about incubation period, how long your child's been feeling sick, or exactly what symptoms they have that could sort of lead to, clarify which illness they're coming down with.
Potentially, I mean, most of the time you don't know when the exposure was, but usually the idea that my child had a runny nose for 2 or 3 days, or a little bit of cough, and now all of a sudden it's a lot worse, is a story that we hear with RSV a lot more than we hear with flu, which is more like I said before, my child was well, and now he or she is very sick very suddenly, and that's a typical flu story. But clinically, from a doctoring standpoint, it's really difficult to tell them apart. I mean, those are sort of generalities about how they're different, but we have to do testing to figure out which one it is. And like you said, we have now tests for all these things. So we could, for example, test for flu A, flu B, RSV, and COVID with one sample.
Wow. So
So,
yeah.
yeah, so it's a lot easier than it used to be.
Right. And then, I mean, with your history in looking at RSV and looking at cases, and I know it's a little too early to tell, obviously based in real world versus clinical of how this, new antibody is going to work. But I mean, does this leave you more hopeful, for cases potentially if we do end up getting this drug before the next RSV season, or if it ends up being the one afterwards? I mean, does this give you more hope as just, dealing with children in your hospitals that this could be such a savior, for some of those children?
Well, absolutely. I certainly hope so. And I don't know whether it'll be available for us in time for this upcoming season, but it might. But I expect it to perform at least as well as the product that we were giving monthly. In studies that compare the two antibodies, it binds RSV better than the old antibody does. And in animal models, it protects better. And in clinical studies, it looks at least as good, if not slightly better, than the one that had to be given monthly. So I think we'll continue to get the same protection we've always had, and maybe slightly better, but with less work and fewer visits for the families.
Right, absolutely. And then, I know there's some other things that are coming down the pipeline that they're still testing, but there was something talked about, a possible vaccine for pregnant mothers, which would do as you were speaking to, give the antibodies from the mother to the child.
Right. So the idea behind that one, like you said, is because little teeny babies, you might say, why not vaccinate the little baby right after they're born? And the reason for that is that little teeny babies' immune systems, they're not as robust as an older person's immune system. So it would be harder for them to make a really good response to a vaccine that was given in the first few days of life for something like RSV. So the idea was, what if we vaccinated the mothers so that we boost up their antibodies? They all have antibodies because everyone's been infected, but we want to boost it up to a much higher level so that that antibody that goes to the baby in the womb will last longer and prevent the baby from becoming infected during the most vulnerable time, which is, between the first 2 to 3 or 4 months of life. If we could make mom's antibodies that are passed to the baby last for 6 months, we would cut down on hospitalizations dramatically. And so that's the idea behind that vaccine.
And that one is much earlier in the process than some of the drugs that we're speaking about. But it does seem that must be exciting to have not only one in the last year, not only two potentially, but then a third vaccine that could be, or a third treatment, excuse me, that could be on the way. So in a year, I mean, we have the elderly one that was passed, and then we have now the antibody that hopefully will be passed shortly. But then, this potential vaccine out there. And before you said there was only one drug. So, what does that say? That did we all of a sudden catch up to some of the research we were doing? Is this just, coincidence that they all are coming out right now?
It's not coincidence. People have been working on this for a long, long time. The virus was discovered in the mid 50s, 1956 to be precise. And there was a vaccine made in the early 60s, but it failed spectacularly. And ever since then, there have been people trying to figure out a good way to come up with a vaccine that would work. And it's been a really, really difficult row to hoe, as they say. Originally, they thought maybe a live attenuated vaccine like the measles vaccine might work, but the problem was that if you made one that replicated enough to protect the babies, it also tended to make them sick. And if you made one that was tolerated well, it didn't produce a good enough immune response. And so I think vaccine technology has advanced, and specifically with regards to these molecules that are called adjuvants, that are things that we put in with the vaccine to stimulate your immune system to produce a better response. And there are better adjuvants now. And I think that's why we're all of a sudden finding success with these vaccines we call subunit vaccines. So the vaccine for the pregnant women and the vaccine for elderly people, they're not live vaccines. They're what we call subunit vaccines. But they have these things called adjuvants that help your body to make a better response to it. And we didn't have these particular adjuvants. They've been developed over time. We never had them before. And I think that's why all of a sudden we're finding success with vaccines against RSV, even though we could never do it in the past.
Right. And even though the RSV vaccine, for the younger age group, that is not really on the horizon right now, at least in terms of public knowledge. I'm not sure. There's studies going on, of course, but how helpful do you think it will be that there was at least an RSV vaccine, for this upcoming season for elderly? I mean, will that take some of the load off of hospitals to maybe focus on younger kids if needed?
Well, maybe. I work in a children's hospital,
Right.
so
Yeah, of
our
course.
focus is always on children. But there is a big problem with RSV in this country in the elderly population, particularly those who, again, just like in kids, who have pre-existing diseases. And in adults, we're talking about congestive heart failure, chronic obstructive pulmonary disease, severe asthma, those sorts of things that lead them to get much sicker with RSV than an otherwise healthy person would get. And there are a lot of adults that are hospitalized with RSV every year. And in certain cases, it is actually fatal in certain elderly people, especially the ones who have pre-existing conditions. And so this new vaccine will really be helpful to protect that group of very vulnerable people.
And, I guess I always ask before we head into this season, and especially if we don't have this new antibody injection ready to go, what are ways that is there a way to prevent RSV from happening? Is that washing your hands? Is it keeping, in distance of people that are sick? I mean, are there some tangible things that parents can do to help protect their kids? Or is it really just so widespread that, there's sort of the chance to get it is always going to be high?
Yeah, that's an excellent question. And the thing about RSV as opposed to COVID and the flu is that RSV is definitely spread in what we call large droplets. And large droplets are heavy enough that they fall out of the ground. Like if someone with RSV coughs, that large droplet won't travel very far before it falls to the floor. And so keeping your children, especially young babies, away from people with any sort of respiratory disease can in fact protect them from RSV. So during the wintertime, especially during the height of the RSV epidemic, if you keep your child away from large crowds, away from anyone who's sick, and if you wash your hands and carefully before you handle your baby and before you feed your baby, and when you go out, when you come back to the home, maybe wash your hands or Purell, you could in fact lessen the chance that the baby would get RSV. It's impossible to make it zero
Right.
because viruses are everywhere, and this one in particular has found a way to spread very efficiently, even though we know that it falls out of the sky. It gets on surfaces, you can pick it up, you can rub it into your eyes or nose. You can't tell a baby or a toddler, keep your hands away from your face. I mean, you can tell them that, but they're not going to do it. So I think the main thing that parents could do is during the height of the respiratory viral season is try to keep their children away from people who are sick and away from large crowds where there's likely to be sick people. I would definitely not allow someone to visit and hold my baby if they're coughing or have a runny nose or have a fever.
Right. And then in terms of, the spread of it, I think that's interesting. I specifically, can't tell you how, germs travel. So it's interesting to sort of hear about large droplets. Those fall shorter than, sort of airborne, is a word that we use a lot, especially in public transportation. You worry about, germs spreading pretty rapidly, and
Right.
sort of
The
staying in the
airborne,
air.
sorry to interrupt you.
Oh,
The
not at all.
airborne ones are the ones that don't fall, right?
Right.
And they spread and they can go through ventilation systems, and they're much more difficult to contain. Um, but we know for a fact that RSV doesn't do that. And I think that's maybe one of the reasons why when COVID first came around, everybody thought it would do what RSV does, right? And so that's where the 6 feet of separation came from, is that we know those large droplets generally fall before 6 feet. But then it turned out that COVID was not necessarily always in large droplets, and it was sometimes aerosolized. But RSV doesn't really aerosolize. And so, I mean, I can tell you the original studies, but they actually had people, medical students, of course, they're good guinea pigs, go into the rooms with babies who had RSV and study for their exams in there. And they had some of them sitting away from the crib. And then they had others who would once an hour come up and stand by the baby's bedside. And they had a third group who would actually pick the babies up and hold them. And the infection rate was highest in the ones who picked the babies up. It was next highest in the ones who every once in a while came to the bedside. And it was virtually zero in people, even though they sat in the room all afternoon studying, as long as they kept their distance from the bedside. And that's how we know that those droplets, that's how we know that it's not aerosol, because otherwise, sitting in that room should have gotten them all infected.
Right. And in that case, timeliness wasn't really a factor either. It was the proximity.
Correct.
Interesting. Well, Dr. Fisher, is there anything else that I guess specifically about this drug that you want to share, or anything coming down the pipeline that you're hearing about, or anything that I guess you might be excited for in the future?
Yeah. I don't know. I think we've covered a lot of the basics about this new product, which I do think is exciting, because the passive antibody for right now is the only way we have to protect these most vulnerable babies. And although the old passive antibody did work, as you mentioned before, it was very inconvenient for the families. This new one, once it's available for us, will be a lot easier. Just come in for one visit, get the injection, and for the rest of the season, it's as though you were continuing to get it. And so that's the most exciting thing about it. As far as vaccines are concerned, I don't know how long it'll be before there's a vaccine for kids, but I think it's great that we now have a vaccine that works for the elderly, and also that the vaccine for pregnant women is moving along and may actually provide the smallest and youngest of those babies with protection without even having to administer anything to them.
Right, absolutely. Well, Dr. Fisher, thank you so much. And, I do hope, obviously, that this antibody injection will get passed, before the next RSV season. But if not, with next year, I do hope in general that the numbers hopefully, do go down and people are able to get the care they need.
I hope so too.
Yeah. Well, thank you so much. And thank you to everyone watching. There will be more information and links available on wavy.com so that you can find out more about CHKD, as well as, the new drug approval. So thank you so much, Dr. Fisher, for your time, and nice to speak with you today.
Thanks for having me. I appreciate it.
Absolutely.